there's a certain amount of inevitability about controlling cost in healthcare in the US, right? Like the percent of GDP number cannot go up forever, and anything that can't go on forever will stop eventually. So I think that the question is how the trajectory of that, how will it be affected by this administration? And I would say a couple of things. Um, there are stakeholders in addition to the administration that are increasingly important. So I would say commercial purchasers, and I'm going to answer your question in a second, but I don't think we should forget that while the administration does whatever it ends up doing, there are other currents and trends that will push our industry. So commercial purchasers, I would also say state governments. Obviously, the dynamics around Medicaid are very important in this administration, both for their other policy goals, but also as a political issue. So, I mean, I'm not a politician, I'm not a policy person, but there's a lot of money there, and states care a lot about it, and so the states will be stewards. Um, Hopefully, so sort of start to transition. I think hopefully the states can be stewards in the Medicaid program with flexibilities that they didn't have before. And maybe it's not that they didn't have them in the previous administration, but that creative thinking that will inevitably happen if their overall revenue availability for Medicaid starts to shrink, the states are going to have to be creative, and that might be a driver of value-based care. Medicaid has always been very thoughtful about whole person care because of the nature of the population that they serve. Um, you know, an important aspect of whole person care that I think states will have to be particularly mindful of, given the positions that the administration has staked out so far, have to do with inequities and sort of attention to health inequities, health outcome inequities. So I would expect that the states will be places where they're carrying that water as they have before. Then the larger federal healthcare enterprise or health payment enterprise. Um, Often, what I think happens is uh, these changes in administration are an opportunity to re-examine the success of previous programs. And we're coming up on decades since the ACA. Um, it it is an appropriate time to ask, like, the signature programs of the ACA, what have they accomplished, what have they haven't, in addition to other programs that have been legislated, Medicare Advantage, I think it is a good thing in a sense that some ideas will be brought in and some questions will be asked. I don't, though, think that the questions that will get chased are actually ones that haven't been asked before, whether in the previous Trump administration or in the interim. There are these questions out there about how to administer managed care. Utilization management is one way to address inappropriate cost. Is health plan administered utilization management optimized? Like that's a question that was being asked 6 months ago. I don't think it's going to stop being asked now. So the scrutiny around MA, practices and coding practices will certainly continue. Um, the sort of signature programs from CMMI, namely the ACOs. Um, so my take on it is that it's going to take a recipe. It's going to take a mix because you need incentives for PCPs, but you also need, I think, additional incentives for specialists that haven't existed yet. And you need incentives for other kind of key stakeholders in the industry. So like, a multi-hospital health system, have they really been incentivized to chase total cost of care? And how can we build a program that will do that? Because the MSSP and the other ACO iterations since then, there are savings, absolutely, that accrue to Medicare. But when those savings are taken out of the revenue stream of the sponsor organization, there's a tension there that I wish we could get past. So how can we set up a system where truly all the stakeholders benefit through more efficient care?